Now start with in the name of the Almighty, most merciful and beneficent. I say that the interpretation was for the 5 Xrays which were given on this date, that is 8th of October. I will call it 6B because there is discrepancy between the previous one. I was not able to answer all of them because of mismanagement of internet problems, you can say. This was the first X-ray I have shown you. A 33 years old known type 1 diabetes mellitus patient who discharged from the ICU about 2 weeks back still had fever and expectoration. Now interpret it accordingly. All parameters should be checked out. Although there are artifacts in this X-ray, discard the artifacts. Other than that, what is the positive finding in this X-ray is there is non-homogeneous radio opacity occupying the right upper zone of the lung field, and the air bronchogram pattern which is seen in this X-ray. This is non-homogeneous, non-uniform with air bronchogram pattern limiting the opacity up to the transfer station. Now this is the X-ray which was shown as the positive finding is this, and remember that the trachea is central. It is not shifted to either side. The other side was more darkened, that is the compensatory emphysema is shown here. These are the positive findings in this X-ray. On the basis of the positive findings in this X-ray relating with the scenario which was given, there should be a differential diagnosis. The topmost differential is a lobar pneumonia, community-acquired pneumonia. Because patient was diabetic patient, and the diabetics, the healing phase of the pneumonia is delayed. Number one, or the possibility of the non-compliance of the patient. Number three, the possibility that dose adjusted was not properly managed by the physician. These are the possibilities of the delayed healing, or the patient was immunocompromised. Possibility that this is the non-healing of the lobar pneumonia. First stage is stage of congestion, stage of red hepatization, and the stage of grey hepatization, where the air bronchogram pattern was seen in the homogeneous opacity. And the last stage was the stage of resolution or the stage of complication. So it is acute inflammation of the lung, and it is in the delayed healing phase. The chronic inflammation of the lung with tuberculosis can present as a pneumonia in our zones, in eastern countries, and they may be present like acute inflammation, so that it is the second differential is the tuberculosis. The feature against the tuberculosis is the secondary effect of the chronic inflammation is not seen. There is a fibrotic reaction in the epices. Epices are clear on the right side, and there is no tracheal deviation, which is against it. The fungal infection can cause like this type of lesion. The invasive fungi, specifically speaking in immunocompromised, can present like that. It may be atypical type of the pneumonia, is possible in this case. But the organisms which are not well known can cause this type of picture. And the tumor and the tumor-like states, for example, the bronchiogenic carcinoma can present and it is hidden inside this opacity. It is a possibility. You have to discard it. If it is after the 4 weeks, it is still there. The other condition which can cause these type of opacities are the autoimmune diseases can cause this type of lesion, although not very commonly. And also remember that the allergic reactions, specifically speaking to the parasite invasion, and the Progonomus rastromani in some countries will cause the opacity, homogeneous or non-homogeneous or diverse. And one is which is called as the aspergillosis, can cause this type of lesion. This is the differential, although the most likely diagnosis was non-healing of the lobar pneumonia. The other investigation I want is the lateral view to be more specific. HRCT where the facilities are available, sputum for the DR, culture and sensitivity, both AFB culture and sensitivity, and gene expert of the sputum. Then blood CBC will show the nature of the disease. Is helpful. Acute phase reactants like ESR and CRP and others, possibility we will do it because it will cause septicemia. The other target organs for the lesion like liver function test and urea, creatinine, electrolyte should be done. Ultrasonography of the upper abdomen should also be done. Now this was the management part, is that you have to control the diabetes mellitus if it is found to be delayed healing, and compliance with the correct drug and with the correct dosages definitely will heal this lesion if it is caused by the community-acquired pneumonia. Otherwise, atypical pneumonia management should be done. If it is not atypical pneumonia, go for the ATT therapeutic trial. And it also fails, you go for the steroids. If they fail also, then go for the CT guided biopsy and see what is this. This possibility that this obesity is isolated to the tumor which is inside. It is possible it is bronchiogenic carcinoma, and still to it there is a pneumonic patch. It is possible like this. The management is this. Accordingly, the second X-ray was a 50-year-old smoker, leather garment factory worker presented with a cough and shortness of the breath since 2 years. The interpretation of this, that is the X-ray, although the quality of the X-ray is not good, sir, all the parts are not visible. For example, the costophrenic angles of both sides are obscured and the lower part of the abdomen is not shown, and the voltage which is given for the XHS PUV, which is 62 to 64, it is higher, it is highly voltage taken X-ray. Now this is the comment, these are technical problems associated with the X-ray. Although the lesions which are shown here are diverse type of lesion, both lung fields are involved. You see that it is the multiple opacities are seen, reticulo, micro, macro, nodular shadowings are visible. Trachea is not seen clearly in this X-ray, so we cannot put comment on the trachea. So multiple opacities in the form of the reticulo, micro, macro, nodular opacities. associated with the scenario which is given here, the most likely diagnosis is industrial hazard, occupational lung diseases, that is pneumoconiosis. Rather, garment factory will use many things, chemicals and the other raw materials they are using. The most likely diagnosis is pneumoconiosis because all lung fields are involved. This is the first most likely diagnosis. Which type of pneumoconiosis is this? It doesn't matter. You have to take it out, the region, and biopsy it. It may be anything like carbon. It may be other than the beryllium, some other material like cotton, bisonosis that is called, silicosis, and others. We cannot say. The second differential which was made, can be made, what is known as the Bronco Pneumonia, can be presented like this. It may be aspiration pneumonia or lipoidal pneumonia, whatever it is. It is possible that these type of lesions can be seen. This type of lesion is also seen in the cases of the acute respiratory distress syndrome. And the chronic inflammation, like for example tuberculosis, can present like that. And the fungal infection can, same type of the pictures can cause. And also in cases of some extensive allergic rhinitis, that is, I call it hypersensitive pneumonitis, can cause this type of lesion because it depends upon the organic particulate matter which is inhaled, and also seen in some cases of sarcoidosis, less than 2% of cases, and in cases of the parasitic invasions, like for example, the most important parasites which can involve are the Ascaris lumbricoides and Ankylostomas duodenale, which can cause a reaction in the lung as a pulmonary eosinophilia. Least likely diagnosis. The managements depend upon general measures, avoidance of the precipitating factors, the patient chest exercises should be done, advise him for the face mask, change his profession, symptomatic measures should be done, expectoration and other things, and you have to do the investigations with lateral view and HRCT and blood CBC and other things depending upon them. If the patient has got the pulmonary hypertension, manage the pulmonary hypertension because this is most likely will lead to the secondary pulmonary hypertension. The third was a 50-year-old housewife presented with dry cough, breathlessness, and coast capitation, maybe fine capitation, mid and the lower zones of both lung fields. And she has showed the digital clubbing. Interpretation is that the trachea you see here is this. It is turning here like this. So there is something going wrong here in this area, which is pulling, because there is no force outside here. The trachea to the same side. Apex here is full of the homogeneous opacity here. Lower down, there is the compensated emphysema in both zones, middle zones, upper zones. Both lung lower fields, they are involved. With what is called is specifically these are ground glass appearance of this. You see with the magnifying glass, ground glass appearance, both lung fields, lower lung fields, tenting of the dome of the diaphragm. Cardiopharyngeal angle is clear, although the coastopharyngeal angle is masked. And there is evidence of the pulmonary conus. Here it is. which is prominent. The overall picture is of what is called the idiopathic fibrosis of the lung, fibrosing alveolitis at one time. Now it is the interstitial pneumonias, one of the interstitial pneumonias, which is fibrosing alveolitis. That is common disease. It is about, in Pakistan, it is 10 to 15%, and mostly women are involved. So this is the most likely diagnosis in this case. But however, the other differentiation can be made with the same picture, the ground glass appearance. That is, the chronic inflammation of the lung should be excluded, like tuberculosis. The fungal infection should be excluded. Autoimmune diseases other than this should be excluded. And the parasitic infestations of the lung should be excluded. Lateral view should be done, HRCT should be done. Echocardiography will help you to see what is the pressure in the pulmonary artery. Go for the routine investigation, complete blood count, the LFT, and the urea creatinine electrolytes, sputum for DR, and for the AFP, culture and sensitivity. Exclude the lesion. Management is that, again I will say, the first part is the general measures. Chest exercises, oxygenation is needed, good oxygenation. Bronchodilation will help in these cases. But the specific measures are, you give the steroids, inhale first, and then you go for the parenteral. Parenteral is more effective. Oral and then long-acting steroids, so suppress the reaction. One investigation should be done, that is rheumatoid arthritis will be positive in 30% of cases. It is the autoimmune nature of the disease. So immunosuppression can be given in this case. And there are a lot of, a long list has been made. Imuran, that azoxystrobin, is a drug which is safe to me. In most of the cases we have given this. And the response is very good, without any effect on the CBC. So we manage this case like this, and if it all are failed, we go for the orthotopic lung transplantation as the last resort. So the other one is the 35-year-old labor had history of refractory asthma. Since 7 years, the CBC showed eosinophilia of more than 21%. Absolute eosinophil count was 2,200. The pulmonary eosinophilia, it means that. Now, trachea here is shifted on this side, although the patient was not in the line. I will not comment. On the right side, there is definitely a lesion is there. And this is the lesion. Look here, all. Very thick reticulation with nodulation, thickened fibrosis here, fibrotic patches are there, and there is aerograms inside it, honeycombing, that is called, on this side. And other side as showing the what is called as the compensated emphysema. The dome of the diaphragm here is all right, and on the left side it is all right, costophrenic, cardiophrenic, again no pleural effusion. So the most likely diagnosis accordingly here is the pulmonary eosinophilia, and most likely pulmonary eosinophilia. Either it is invasive type of the aspergillosis, or it is the Lopfler syndrome that is caused by the Scarus lumbricoides or Encrustomatoidinal and other worm infestations. Or directly the Paracormus stomani can cause this type of lesion. Eosinophil count is the marker here. The other differential you can make is the chronic inflammation. As a result of the chronic inflammation, tuberculosis in this country can cause this type of a picture, or the fungal infection in immunocompromised can cause this type of the picture. And then the other autoimmune diseases can cause the fibrotic reaction in the lung. And for example, ankylosing spondylosis will involve the apices and the lower zones. On the unilateral lesion was only, if it is extensive, it will cause the other parts to be involved. So the lateral view should be done, SRCT should be done, sputum for the DR, etc. should be done for AFB to exclude it. And the other parameters, the routine parameters should be done. And you have to address the primary disease of the lung, confirm it, and then manage it. Usually the inhaled steroids are given with the parenteral steroids for a prolonged period of time, so that the lesion will be subsided gradually. Specific antifungal drugs are not used in this case. Deworm the patient if it is, you have got evidence of ankylosing spondylosis or the escalation of aquatis. That will be the very important management part. We use the albendazole or mebendazole for a prolonged period of time to suppress this count. It is directly proportional with the radiological appearance. It is down and down and down. This lesion will be resolving when you are giving the anti-worms. The primary pulmonary eosinophilic pneumonias or eosinophilic pneumonias or hypereosinophilic syndromes are all included in this. Management is the same of the pulmonary eosinophilia is concerned. A 60-year-old smoker experienced severe breathlessness and central chest pain crushing in nature where he was fixing the car flat tire. It is one of the easiest X-ray in the fight. Look, the trachea is moving on this side, on the left side. And this part, you see, the cardiac shadow is not visible. There is solid sign. Borders cannot be explained. There is the whole right hemithorax shows the absolute hypertonsillency. No bronchovascular markings is visible. Whole lung is involved of this female. And look, this part, this is the lung, which is remaining lung here. This is trachea, principal bronchus, which is diverted here on the side. So this is the medial shift with the pneumothorax spontaneous by the fixing tire flat. Probably emphysematous bulla was there because he was a smoker. Probably it bursts out and causing this. It is possibility of this cause. The medial shift is there. If it is medial shift, the secondary effect of the pneumothorax, this is tension pneumothorax. This is a medical emergency. Whatever is available should be done. Needle should put on the higher side and take it out as quickly as possible, and then plan it for the surgery performed and put a underwater seal. The other investigation could be done with the lateral view and should be done with the HRCT. It should be done etiologically, sputum for AFB and gene expert, etc. DR. And other routine investigation should be done with it, because the heart is actually compromising here. So do it as quickly as possible. The air should be out by any means, by hook or by crook. So elective procedure will take time. So emergency procedure, that needle should be put on the intercapital line posteriorly, put it down, deeply inserted, so the air will hush out and the lung will be gradually come to the normal here. And then electively do the underwater seal, the lung becomes gradually normal and normal and normal. If there is no bubbling seen in the underwater seal, then you will close this wound permanently. This is how we manage this case. I hope that this discussion is enough to tolerate, and we will inshallah meet again on our next session. So goodbye and good luck.